Hello, everybody. So my name is Mary McDonagh, and I'm a senior physiotherapist working in the Assistive Technology and Specialised Seating Department in the CRC in Dublin. And I'm also a part-time PhD student. So today I'm going to talk about my study, which explored the perspectives of paediatric therapists on the use of and provision of custom contoured seating for children. So just a brief overview of my presentation. I'm going to touch on my research topic, the outcomes of the literature review I conducted, the research framework I'm using, the study rationale, methodology and findings, and future studies I'm planning. So our topic is custom contoured seating, and we refer to it as custom molded seating really in Ireland more than custom contoured. And this type of seating is prescribed for children with neurodisabilities for whom standard or off-the-shelf seating does not meet their complex seating needs. And this type of seating can be interfaced onto manual or powered wheelchairs, and you can also get custom comfort seating. This type of seating can be costly, and their provision involves more time and clinical resources compared to standard or off-the-shelf seating, and there's limited adjustability for growth in many of the systems. And in clinical practice, diverse opinions exist regarding when a child should be referred for molded seating. Sometimes we see children who come into our clinic, and we often think if we had seen them sooner, we would have probably cast them ages ago. And they might be 11 or 12 years old and have quite asymmetric postures at that point. And you're kind of wondering, why was the child not referred sooner, for example? So I conducted a literature review looking at all results, including academic journals, trade publications, and conference proceedings from 1967 to 2021 in the English language. And I looked at CINAHL, Medline, Cochrane Library, and PubMed databases. And my search terms were custom and molded seating, specialized seating, complex seating, custom contoured seating, and adaptive seating. And this is further expanded to include pediatrics, clinical outcomes, and standards of practice. And what I found was there's limited clinical studies specifically related to custom molded seating, and some of the earlier studies have low methodological quality. And mainly they can be grouped into four main areas: the manufacturing of these types of seats and the different options available, the clinical studies I mentioned. There are standards and guidelines related to wheelchair seating and assessments, but not specifically really to molded seating, and expert opinion. So when it comes to gaps in the research, there is a lack of research exploring the perspectives of therapists who refer to specialized seating services on the use of molded seating for children and the way services provide them. There's also a lack of peer-reviewed research exploring the views of children and their carers on the use of this intervention and the services providing them. And in the context of progressing disability services in Ireland, PDS, and what I mean by that is there's been a complete reconfiguration of the way disability services are being provided for children in Ireland. Predominantly, there used to be a lot more focus on physical disability, and not so much on sensory. So now they've both been combined. So all pediatric services have to provide both. As well as this, there's a lack of studies measuring the impact of molded seating on children and their families using meaningful, valid, and reliable outcome measures. And there is no evidence-based guidelines or recommendations specifically related to the assessment for and provision of molded seating. It's intended that data obtained from studies in my research will be synthesized to underpin and validate the development of best practice recommendations in relation to the provision of custom molded seating for children. So the framework I'm using for my research is co-production. And as we all know, co-production forms part of the spectrum of public and patient involvement and engagement, or PPIE, in research and healthcare. And this provides a chance for researchers and healthcare workers and the public and patients to work together to create, redesign, and generate research knowledge. PPIE can improve access to seldom heard or marginalized voices and reflects nothing about me without me ethos that has become accepted policy in the way services are designed to meet the needs of end users. And co-production has been shown to positively impact healthcare outcomes through improved cost efficiency, health outcomes, perceived quality of life, service accessibility, patient satisfaction, and compliance. So how am I using co-production in my research? I am working closely with a panel of senior clinicians with experience in molded seating and OT, physio, and clinical engineer who are not working in my service, as well as panels of parents using molded seating. So I will work closely with them so they can provide guidance on topics and questions for the focus groups and interviews I'll be conducting, and they'll be given feedback on study findings, and they'll also be involved in helping prioritize key areas of focus in developing the best practice recommendations. So the aim of my first study was to explore the thoughts, opinions, and perspectives of referring therapists on the use of custom molded seating for children, as well as the processes and services involved in their provision, and also when and why they felt custom molded seating should be considered and recommended for children with complex needs. The methodology I used was grounded theory, and it involved 3 online focus groups with 15 pediatric therapists working in community disability network teams, pediatric hospitals, and specialist pediatric services who refer into us. Grounded theory is best suited for studying a phenomenon with little known information to generate a substantive theory that will explain social processes or actions about the focus of the study. And within focus groups, as we all know, members can respond and react to the interviewer and each other. So this can stimulate debate, allowing people to generate new ideas and questions and answers about a topic, as opposed to relying purely on the researcher or a single participant. So ethical approval was obtained from Ulster University and the Central Media Clinic, and sampling for the study is purposive, and I selected therapists who refer to all 4 centres. We have 2 in Dublin and 1 in Waterford and 1 in Limerick. Invitations were sent by our admin coordinator, and interested therapists were sent a participant information sheet and consent form, and they're given a 2-week cooling off period. So the focus groups were took place online, and they were audio and video recorded using Zoom, and Otter software is also used for audio recording. Otter software recorded and transcribed the data in real time, which is really handy, and I recommend that. And the recordings were checked for accuracy, and participants were assigned identifier codes to ensure confidentiality, and any identifying information was removed. So when it comes to data analysis, for grounded theory, this involves an iterative inductive process achieved by carrying out 3 types of coding: open coding to find the codes and categories in the data, axial coding to interconnect them, and selective coding to establish the final core category. So each focus group transcript is read and reread. So I became familiar with the data and noting ideas throughout. And then data were organized into a series of codes, and this consists of short statements or labels that capture the meaning of phrases and patterns in the data. And then codes were then grouped into categories, and these codes and categories were combined and contrasted until theoretical saturation was reached, resulting in 5 core categories, which were mapped and further analyzed to develop as a substantive theory. So when it comes to trustworthiness, another member of the research team checked the transcriptions for accuracy, analyzed the data separately, and then we met to agree and confirm codes and core categories, overall theme validity, and check for bias. And also respondent validation took place to ensure the themes accurately reflected the group's perceptions. And I recorded any assumptions I was bringing into the research process to identify preconceptions and not impose a pre-existing frame on the data. So the 5 core categories from my research were that prevention is better than cure. Custom molded seating is still considered a last resort intervention. The emotional impact of children and their families when it comes to using this type of seating intervention, the challenges involved in getting it right. And another big one was the disparity in access to and the quality of seating and services at a national level in the context of progressing disability services. So overall, product, process, and service-related constraints influence therapist decisions to refer a child for custom molded seating. So I'm going to go through the different categories. So the first one, prevention is better than cure. So when it came to the rationale for referring a child for custom molded seating, therapists spoke of prevention of pain, pressure, and the progression of musculoskeletal deformities. And as well as that, they spoke of the facilitation of achieving functional goals. For example, to provide a stable base of support, so a child can self-propel a wheelchair or access AT, such as an AAC device. So the next one. So even though therapists acknowledge they're open to referring children at an earlier age because they could see what the benefits are, particularly in relation to comfort and children needing less repositioning throughout the day, and also say for children with progressive conditions, it's still considered in a lot of cases a last resort intervention because of 3 things. One of them is the cost of the seating system, growth obviously, because a child is going to grow out of something customized quite quickly, maybe compared to something that's off the shelf. And another major one was the timeframes. The timeframes involved in actually accessing the service in the first place. And we have one quote here, and it says, they grow so fast, you can't keep up the mold. Sometimes, you know, by the time they get their appointment in the CRC and the time funding has come through, they've gone through 3 growth stages. So I suppose in that sense, for the younger ones especially, it would often be a last resort. I'd try a lot of other options before I get there, whereas if it's another child, I might get there a bit faster if I thought it would better meet their postural needs and their participation needs. So the emotional impact on children and parents. So therapists spoke of, say, younger children. Sometimes families have difficulty coming to terms with the fact that their child needs to use a wheelchair and needs this level of support in sitting. And as well as that, another thing that came up is that sometimes children just do not like the look of these seating systems. We use a lot of foam molded seating systems in Ireland, and they can be quite bulky compared to other options. But this quote here, I have 3 children with progressive conditions, 3 bright children who just didn't like the look of the mold and rejected it on that basis and refused to go into the mold because they did not like how it looked. So therapists spoke of the challenge in getting it right for children and their families. And molded seating can sometimes be considered quite restrictive. It has to be close contact fit, quite supportive. And sometimes that can maybe impact function, getting the balance between having supportive seating that's going to protect their body structure, but also happen to enhance their function and participation as well. It's really complex to be able to kind of marry the two of them. So you're always nervous when with a custom seat. Another thing that came up also was with custom seating, you only have one shot to get it right when you're casting a child. So if a child's unwell on the day, or they're not in good form or different in any way, then you could end up with maybe not the seat that you wanted, essentially. Therapists spoke of what they felt is the disparity in access to and the quality of seating and services in the context of PDS, particularly therapists who work in national services. So they would see children coming to them from all over the country, and they would feel there was just variability in the quality and standard of seating being provided. Therapists spoke of frustration and stress coming to terms with progressing disability services, with lack of staff being a major cause of concern, particularly senior staff, and this fear of missing out on making referrals in a timely fashion for either assessments or seating reviews, and that there was a lot of concerns regarding safety when it comes to equipment provision, particularly with more junior staff having to all of a sudden be in that position where they have to prescribe seating. Therapists spoke of how that you're expected to be almost an expert on everything, and you're expected to learn on the ground, and they end up maybe relying a lot on engineers and reps to help them in the decision-making process. And there's a feeling there was a lack of clinical leads or specialists around complex seating in the country that would help guide pathways and processes and just be a go-to person for therapists with queries and questions. So when it comes to trying to come up with solutions for this, therapists spoke of the need to really establish equitable access to services for children, but that if it needs to be a national approach as opposed to being done sort of differently in different regions. So there's consistency across the board. Everybody knows what referral criteria are, and everybody's doing the same thing. So pathways and processes and things like that. So when it came to the services that we're providing in our department, therapists spoke of satisfaction with the service. Usually it's a very good outcome, but the one major issue was the time frames, just the waiting times to get into our service and access our services can be a long time from the time of referral to the time the child's actually sitting in a mold. Therapists appreciate the outcome of the outreach services. So when we can travel to their services to work with them, that was something that felt worked quite well. However, there was also a need highlighted to improve communication between our service and the therapists who refer into us. So essentially, yes, the study has shown that product, process, and service-related constraints can impact therapists' decision to refer children for this intervention. So I suppose the findings indicate the need to examine current processes in the specialized seating service to improve efficiency and access for children and improve communication with the wider team. There's also a need for engagement with manufacturers and suppliers to devise solutions that maybe allow children to use their seats for longer where appropriate, examine costs, and improve on seat design. And also a need for clear indicators for referral, consistent processes and pathways, as well as the provision of training and education, along with clinical specialist support for therapists on CDNTs. So the next couple of studies that I plan to actually conduct would be to explore the perspectives of children and their carers on this intervention and the way services are providing them, as well as the perspectives of clinicians working in specialized seating services who provide these seating systems on a daily basis. And alongside that too, I think it'd be important to conduct quantitative research as well. It's quite difficult sometimes to conduct research when you're talking about custom seating, because everybody's different and they all need a different type of system. But at the same time, I think it'd be really useful to use single subject research design and use valid and reliable outcome measures, such as the care and comfort questionnaire, the CP child, so that's quality of life, along with the posture and posturability scale. So really valid and reliable outcome measures when it comes to single subject research design, just to help add to the evidence base supporting this intervention. So yeah, that's me finished. If anyone has any questions.
That's good. It was very good. I'm still processing it all, but yes, how do we know when to do it?
Yeah.
And what influences that decision of when you finally go in for the mold? That's
it, yeah. And it's interesting because therapists know the benefits and they will say that, but at the same time, there are barriers. Yeah, of course.
This study in 3,
Mm-hmm.
if it's perspectives of experience of the children. So I might have missed it. Is there an identified age range? And
yeah,
you know, that I guess it's not really a question. It's like I'm thinking, what type of comments will we get from what age of children?
Yeah,
about the perspectives.
I think, yeah, that's a good question. And you don't want to exclude age groups either. So I think certainly I would be planning on using interviews, first of all, semi-structured interviews as opposed to focus groups of children. But I think 12 to 18 would be a good age group, you know. Yeah.
I think it's great. I think it's great to ask the kids.
Yeah.
What do you think?
Of course, yeah. Yeah, exactly. Get their opinions on it. Yeah. So for sure.
Just during that time period of life.
Absolutely, yeah.
Were the kids ever specific about what they did?
So basically, I suppose we didn't get into that really, you know, but yeah, it was just something that came up, but it didn't. Yeah, I mean, I suppose I'll get a chance when I do study 3 to find out a bit more about that. But yeah, so these were just referring therapists, so they didn't get into major detail on that particular aspect. Yeah.